Hello, I'm Paul Baker and I'm joining you from Auckland, New Zealand, and I want to talk to you today about learn, unlearn and relearn. I do have some conflicts of interest which you can see on the screen, and I think they're also on the website. So, first concept I want to discuss with you, I'm going to call the trickle-down effect. And really what I'm on about is the dissemination of information from the beginning, which often is clinical research or evidence gleaned from other sources like book chapters or lectures, which filter into recommendations and appear in practice guidelines. From there, hopefully, they are taken up and adopted by clinicians in their clinical environment in the hospital when they're looking after patients. And that may hopefully result in some new knowledge, new skill, and new behaviours. And of course, the ultimate result of all of this, we hope, will be an improvement in patient outcomes. Now, first, let's have a quick look at practice guidelines. Practice guidelines have been with us for decades. This is one of the older ones. It's the ASA Practice Guideline 1993. And they come with recommendations which, as I've already said, usually arise from research and peer-reviewed information. So it's reputable information that has been scrutinized before it finds its way into a guideline. In this particular guideline, there was a recommended strategy for intubation of the difficult airway, and it included the identification of alternative approaches that can be employed if the primary approach fails or is not feasible. Now, you probably notice that there's a certain sameness about this concept because, in fact, it's an old idea described by Albert Einstein. He said doing the same thing over and over again and expecting different results is the definition of insanity. Now, moving on, let's talk a little bit about clinical research. And this was an absolute critical piece of information that came from Thomas Mort from the US, where he made an observation in his own intensive care unit that a significant increase in morbidity occurred as a result of laryngoscopic attempts increasing beyond 2 attempts. And the morbidity he was talking about was hypoxemia, regurgitation and aspiration of gastric contents, bradycardia, and cardiac arrest. So that was in 2004. Now let's leap forward again to 2011 when the NAP4 was published. Now, for those who aren't familiar with NAP4, this was a massive undertaking in the UK. It was the fourth national audit project, and it was all about major complications of airway management. So they audited over that 12-month period 3 million patients and had 184 reports. This is from chapter 21, which involved children, and they found harm arose due to repeated attempts to intubate the trachea without change of technique. So here we have a combo of the last two slides. So first of all, in 1993, I showed you in the ASA guideline a recommendation that if your first attempt failed, you should change into some other technique. And then Thomas Mort came along and told us that repeated intubation attempts resulted in an increase in morbidity. So it was found in the NAP4 audit, the same thing. Several years later, the same thing still happening. Repeated intubation attempts and practitioners failing to change to another technique when the first one failed. Now let's go ahead again to 2017, and this is a multi-center study in Europe involving 261 hospitals looking at critical airway events for the pediatric population. And the evidence found that the incidence of critical respiratory events increased substantially when more than 2 attempts were used to secure the airway. Same old story, I'm afraid, but in a different time. But it just doesn't seem to go away. So here we have a recommendation. And this time it's from the other side of the Atlantic in the US, where they did a multi-center study again, involving 1,018 children with difficult intubations. This was the PeDI study, and the recommendation published in Lancet in 2016 was that to limit direct laryngoscopy attempts to 2 and rapidly transition to an alternative technique. And in this case, they recommend flexible bronchoscopy or video laryngoscopy. Now we'll just change tack for a moment and let's talk about oxygen treatment. So again, the same PEDIT study, and here's some evidence about hypoxia. So they defined critical events into non-severe and severe complications. And the most frequent non-severe complication in the PEDIT study was temporary hypoxemia. And that occurred in 9% of the 1,018 children. The most common severe complication in this group was cardiac arrest, and that occurred in 2% of the difficult intubations. The interesting finding here is that all of those cardiac arrests were preceded by hypoxemia. They were all respiratory arrests. So it would seem that the solution is pretty obvious. Recommendation published in an editorial the same year by John Fiaggio, oxygen supplementation during prolonged tracheal intubation should be the standard of care. Common sense. Why don't we all do it? Well, recommendation again, here we are, back to 2013, but a very similar recommendation. Practitioners should actively pursue opportunities to deliver supplemental oxygen throughout the process of difficult airway management. All good common sense. What actually happens? What happens when you move down through from recommends and guidelines to actual clinical practice at the coalface? Here's the application in the PEDIT study. What happened? So oxygen was rarely given during tracheal intubation. In fact, less than 10% of the patients received oxygen during difficult intubation attempts. What about monitoring? Well, here's some good evidence. This was an interesting study, actually. It looked at the use of monitoring from the operating room to the PECU. And we all have known since the 1980s that it's a good idea to apply oxygen in the unconscious patient when you're transporting them from the operating room to the post-anesthetic care unit. That's been practiced pretty well worldwide and it's well known. But what about the monitoring? So in this study, they looked at the application of a pulse oximeter in that journey. And they had about 1,000 patients and they randomized them. They all received oxygen for that transit period, but they randomized so that only half of them actually had a pulse oximeter on. And lo and behold, in the group that had the pulse oximeter, there were no hypoxemic events on arrival in the PECU. In the group that didn't have a pulse oximeter, there were 6 hypoxemic events, and that they found was statistically significant. So there's some evidence in support of not only delivering oxygen during transport for unconscious children, but also monitor them. And so from this comes a guideline. They didn't necessarily apply that particular study, but that sort of evidence is probably what was behind the recommendations which have been published this year. Now, this is, of course, targeting the UK environment. It was published in Anesthesia earlier this year. And here's a recommendation for monitoring during transfer within the hospital. And they say that the standard of care and monitoring required during transfer of patients who are anaesthetized or sedated is equivalent to that required in the operating theatre. And they say this includes patients who are being transferred from the operating room to the PECU. So here's a recommendation that it's a good idea to apply monitoring during that journey, as well as delivering oxygen. So why don't we do it? Seems simple, doesn't cost much. There's good monitors that you can do this. What about the application? Well, we don't know yet. I know around in my hospital, there's variable uptake of this concept. Some parts of the hospital have jumped at it and they do it on all patients. Other areas don't. I'm not quite sure why, but it is not a standard in our part of the world at the moment. It is not an edict from the college, for example, that we have to do this. So there does seem to be a bit of a disconnect. There's an abundance of evidence. There's an abundance of guidelines. There's guidelines for just about every country in the world. There's people beavering around all around the world, generating these guidelines, sifting through screeds of evidence. Takes an enormous amount of time and energy to come up with practice guidelines. And we hope that those practice guidelines are actually taken up by the practitioners. And then the ultimate prize is that they're adopted for patient care and to see an improvement in patient outcome. But sadly, this is not universally the case. There is a disconnect. Now, I don't have all the answers for why there's a disconnect, but there is, and I think this is a critical point in our efforts to improve airway management, that we get to the bottom of this problem. So why does it happen? Well, it could be something to do with our brains, I guess. We just don't necessarily want to apply these things, or we don't have the application, or whatever it is. Here's an interesting little study I just happened on in the journal Neuron, and it involved aged mice. And it seems that as mice grow older, they are far less inclined to adopt new ideas. So parts of the brain that is responsible for adopting new ideas and improving goal-directed action deteriorates. So the poor little mouse, as it gets older, it can't adapt. Maybe there's a message there for humans. But more likely, I think it's a behavior thing. And there are various aspects of our behavior that are counterintuitive and counterproductive, rather, when it comes to learning and adapting new ideas and applying them to our practice. Here's just a few that I've observed over the years. So behavioral factors, I think, are part of the problem. So, for example, some individuals feel secure by maintaining old practices. You know, we feel comfortable in what we've done for years. It seems to work. Why should we change it? So old habits die hard. In some places, there's a culture, and a culture can develop within institutions. So that's how it's done here. We like to do it that way. That's our practice. Institutional practices remain unchallenged. We've always done it this way. So new people coming in who have new ideas are not necessarily welcome. Rare problems are forgotten until next time when they happen again. So the cry, I've never seen that happen. Well, that often means people haven't seen enough, because rare things have a nasty habit of reoccurring. Change can be unpopular and threatening. Don't rock the boat. We're very happy with the way things are. We don't want that new idea, because what we're doing is fine. Some people don't like being lectured. Oops, don't tell me what to do. Implementing change and learning takes time and effort, that's for sure. It takes time out of your normal routine to go off and read things, study things, spend time in the evening, on weekends, and go into courses, etc., etc. I'm far too busy for all of that. Fair enough, we all suffer from these things. So how do we change this behavior? Well, these are just a few of my ideas, and I'd really like to hear a discussion about this sort of thing, because I think it is a legitimate problem. We could use our airway leads, and I'm sure most of you know that the airway leads idea is starting to move around the world. There are now airway lead networks in the United Kingdom, Ireland, New Zealand, and Australia, and other countries I know are seriously looking at adopting airway leads. And airway leads are people who work within the hospital and enact change. So they're responsible for education and training, audit, making sure equipment is up to standard, and promoting practice guidelines. So that's a nice way of doing it, having one of your colleagues who's in charge of that sort of thing and just helps you along to improve standards within your department. Or we can rely on regulations, college guidelines and college regulations that we have to follow. And woe betide you if you are in trouble and you haven't been following the guidelines. Or CPD requirements. If you don't keep up with the number of courses you're supposed to do in a year, you won't get enough points and you won't get your practicing certificate. So that's a sort of fairly rigid way of making sure you keep up to scratch. Or just the good old-fashioned way of education, learning on the job or learning in skill centres or learning human factor training, skills training, and improving your knowledge. So all those things are very important to improve the standard of care. And then there's environmental change. So if somebody is a fanatic in your department and they want to lead the way, others may follow, and that's good. Or stock takes, simple things like in our department, for example, we improve the use of apneic oxygenation by nasal prongs simply by storing in the drawer in the operating room rather than keeping them in a remote place like in the PACU. That had an instant effect and it was very effective. A very simple little change. So I hope we can generate a bit of discussion about this topic. I drew the idea from this quote, and it was by Alvin Toffler, who is described as a futurist, and he wrote a book called Future Shock. And his quote said, "The illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn." And I think we should all ponder about that. It's worth thinking about and maybe discussing later on. Thank you very much for your time. I've appreciated being able to talk to you, and thank you. Wish you the best from New Zealand.